All right, well, thanks a lot. I really appreciate people listening to my talk, and I really appreciate the invitation to talk about hip resurfacing. There isn't always a lot of interest in that. Just to make clear that I'm going to talk about some stuff that's new, but we don't actually have it in front of us for the most part. This is what we have mostly used and are still using when we need hip resurfacing. It's the old buccal pappus. It's been modified over the years, but not in any important way. The basic design of the systems remain true. It's a ceramic-coated titanium implant. It now has highly cross-linked polyethylene. Almost every implant, hip, knee, or shoulder would. It's a three-piece implant. Like most standard total hips, that polyethylene comes out of the shell, allows you to interchange it if you need be, get a supplemental fixation if you need it, any other purpose. Why talk about hip resurfacing at all? There are people thinking a total hip will solve all problems. I think if you see this patient come in your office, you might think again about that. You can look up the top of the pelvis and see that the wrist sign's incomplete. This is a kid. He's full size pretty much, got a terrible problem with his hip, and that's a vascularized fibula that was put in there. It's cortical bone. It wasn't any clear way how you, even if you wanted to do a total hip, how you're really going to broach that femur wasn't clear. Would you want that anyway for the kid? What are you going to do with that screw? So you can see what we did. This is a kind of a case that I would see on a pretty regular basis. It makes me never quite disregard hip resurfacing as a concept. This would be another, and this is a more common thing because IM rods have been around a while. This is an old Schneider self-broaching nail. You can't get these out. They were wedged in. That's a solid nail, famous for how difficult, if you ever had to. Once the fracture heals, that's it. This rod's in there for the duration now. And you can see the femur's kind of dicey anyway. So again, a time when the better choice for the patient, hip resurfacing. This is a time when I don't worry about the age. This patient was nearly 80, just had to do it as the least path of least resistance. Here's an indication that I see with some regularity. Admittedly, there's other solutions here that might be workable. This is a patient of mine, saw in follow-up here recently, had the left total hip was done first. You can see the radiolucencies around it. This had not worked out. Admittedly, they could revise it. Maybe you could make it work out better. But the patient, when they had their other hip, just didn't want it. They wanted to try something else. I think that made sense to me. It did work out. Ultimately, we did it. The hip on the right has worked for the patient, where the one on the left never really did. It's just painful. He can walk on it, admittedly. So those are the kind of things that you think of when, wow, why resurfacing? Why not just a total hip for everybody? This was the watershed year for me. I think about the many years I've spent, 42 now in practice doing this, and actually learned resurfacing as a trainee before that. Chit Ranawat wrote a letter to the editor questioning hip resurfacing. Said it wasn't a good idea, that a regular total hip replacement could solve all ills. And I was thrilled beyond belief, even though it was a critical letter, to think that Chit Ranawat, who I'd looked up to since I was a trainee, even knew my name and would bother reading something I had written and commenting about it. There's a picture of me seeing him later. I thanked him profusely. It was a real awakening for me to get to that level of life. These are some of the other great friends that I've had around me in resurfacing. Derek McMinn in the center on the right, Tom Gross. And there's my original partner on the photo on your right, on my left, Dr. Mayo. And between us is a French resurfacing surgeon who I know well. So I've been privileged to know some of the people who really matter in this field, resurfacing and hip in general. where do I just found this out recently, even though it's been out there for years. The American Joint Replacement Registry, I convinced the hospital when I was chief to contribute to it. We have since it started in 2012. And the last comment there, under hip resurfacing, almost a third of the procedures were performed by a single surgeon. That's me. And I did not know that until just recently here. And I looked it up some other years, same thing applies. They're no longer tracking resurfacing much because it's fallen off as the metal on metal era, but for much of the time. And people can just look in that registry and find out if what we're doing really does make any sense. That's the biggest registry in the world. What you can find out, if you want to, it's a pretty safe operation. The complications are in there, the outcomes are in there. No one's found that resurfacing is dangerous in some way. So I think this is kind of settled. What's new? That's the polymotion. All the rage, clinical trial run out of Montreal. Interesting looking implant. The polyethylene is welded in a neat way to the backing, and it's cemented on the femur. It's the original kind of a Birmingham type femur, and it's the same guy behind it, Derek McMinn, a good friend of mine. There's the people that Jim McKenzie with Derek and I know them both well. There's a picture on your right of Jim McKenzie coming down to watch me do a buccal pappas at the operating room here in Seattle. He was very proud of the work he was doing on the polymotion, but he also saw a role for what I'm doing, an ongoing one. I was interested to talk to him about that. And so this is after the trial started. He came to Seattle twice to see what we do. And we took him in the OR and showed him everything. So I'll show you a new implant because people always want to know what's new. This is not available from me or anywhere in the United States yet. It's been done though. There's the post-operative films, polyethylene-based hip resurfacing, and titanium nitride coated, cobalt chrome rather than titanium base like I'm using now. Why a new system? Well, there's the reasons that you might think of behind it. And just a recap of bone stock and larger femoral geometry, the historic reasons. I think I'm more persuaded by just the absolute essential nature of the problem than the specifics of resurfacing anymore. Originally, those were attractive features to me, the art of my patients. But I think just the problems that I see that just call for this are more compelling now. But those same things are, of course, still as true today as they were. A life-size hip is more stable. There is a better sense of where your hip is in space, no doubt. So here's incorporating all the bells and whistles that we now can see. Vitamin E crosslink, not just crosslink, vitamin E. And then new textures with, there's no limit now. Instead of just plasma spray and sintered beads like all of us have had to accept since the late 1980s, we now can just create any texture, and this one's done it on a resurfacing implant. This is exciting stuff. Maybe this will be better, faster, easier, cheaper than what we've had. Hope for all those things. Don't know any of them yet, but it's exciting that it's so different. It's not just a kind of a gradual creep change. There it is, 3D metal. Pretty neat. Layer by layer. Early osseointegration. Superior mechanic can't break it as easily. I haven't seen a resurfacing socket break anyway, but this stuff's even stronger. Demanding conditions. Tin coating. We're seeing a lot of that now. This is going to be one in a big way. It has some niobium. We're seeing that on knees. Patients seem to want this whether it's any better as a wear surface or not, because of the thought that maybe it's not really a metal, it's a ceramic, and they won't be sensitive to it. I think that patients want that. It certainly does work well enough. This new system of size range, 12 sizes, that's a pretty good range. 2 millimeter increments. This is going to cover most everything. If we think of the constraints, I don't have them with the implant I'm currently using, but the Birmingham only offered from 48 millimeters and up recently. That was basically women couldn't have it. So this solves it. System with extensive size range. And why couldn't we get that with fully ceramic? It sort of mentions that I've been asking about this for years. Why did our ceramics stop, big ceramic balls, for instance, at 48? People who got bigger than 48 in their hip, heck, we see hips all the time, 52, needs another size. Again, why a new system? Here's all the things about it, the options. Could you combine one system with another? Could you put a ceramic, entirely ceramic one rather than just coated? All the possibilities that you could have. Pretty much endless, exciting stuff. Surgical technique. I kind of take this for granted now because I haven't been using a femoral guide in a number of years. I've gotten so accustomed. Admittedly, I make it look hard. I have to walk around the room. I put the guide pin in I use. I look at it from the other side. My assistant might comment whether they think it's any good. We collectively get it in. But if you had a guide that this implant supports, it'll just put it in for you. That'd be great. Maybe we can go faster. The cup. This is, right now, we've been using technology with a two-piece cup so you can independently change it. We know how those work. We're so accustomed to them from regular total hips. What if you wanted a one-piece cup? Easier, faster, don't have intraoperative assembly. Here's how it goes together. And a way to really make it so it's secure and yet thin at the same time. Think of what a challenge that is. This is really thin. And take it out to the edge like that. They've done it. This is an implant. Now I showed the x-ray, it's going in patients. An impaction system. Got these little pegs so you can grab onto it with it pretty secure so you can get the angle better. That's been tough for one-piece cups. Never been a good way. Maybe this will be the way to grab onto that with security, to get it oriented the way you want, which is, we know, always important. Testing. You got to test the heck out of these things. Should anyway, to make sure that they work in your patients. Going to have to test it in a great way. And this is a system that's done all that. The mechanical test it bore up. It did these things. The liner didn't separate. The stems didn't break. Wear test. So it mechanically stood up. Also, the wear's decent. These are simulators, of course. These are not wear tests done on patients like we really need. What we really need, as we all know, retrievals. This is a new implant. It's only been in a person since July so far, but the test looks good. Fatigue failure, same thing. Edge loading, implant passed. 10 million cycles. And look at how well it's done. The loads put on it. Made it through all of them. Push out, lever out, torque out. These are things that, again, you have to do. We've typically done these with our two-piece cups to make sure our locking mechanisms don't give up that liner in ways we don't want it to. It's just as important, though, with a one-piece. Again, even with frightfully thin as this has, both the backing and the liner passed. Reaming, impaction, deformation. I spent a ton of time on deformation, and now we got an implant system where the deformation's been figured in. This is what kills a lot of the metal on metal implants. If they deformed when they went in, then they didn't match each other well enough, causes a metal reaction. Just as important with polyethylene, or more so, you've got to understand the deformation, you've got to test for it, you've got to know what it is when you do it. Because if it deforms too much, it can become eccentric, or it can not have enough clearance. If it doesn't have enough clearance, it'll have runaway wear. So really fabulous testing behind this. People that gave input, certainly I did, and then not much from America on this, only a couple guys. There's not a bunch of input. These are some dedicated people around the globe, Australia, England, France, and a couple of token Americans. Just to remind you, we don't have all the glorious things I just said. I want them all. Hopefully it's coming. This is what we got today. Thanks a lot. Anybody have any questions for me?